Hello there, and welcome to the Protocol Manual meetup on the post-pandemic healthcare revolution. I'm Mike Murphy, the transformation editor here at Protocol. And as you may know, Protocol launched about 5 months ago now with the aim of focusing on the people, power, and politics in tech. Last week, we published our healthcare manual, which this conversation is springing out of. It's illustrative of our commitment to not just dive deep into tech and the biggest tech companies out there, but to shed light on how major industries like healthcare are being impacted by tech, especially now during this pandemic. And we appreciated Phillips's partnership on the manual. Today, we wanted to bring some of the conversations we had in the manual to life. Also, if there are other areas like this and these big industries that you feel as protocol readers that you'd like to see us dive deep into, please let us know. And before I introduce our panelists, I just want to remind anyone who's listening that if you want to ask questions, please do so with the Q&A function. We'll be monitoring that throughout, and I'll remind you guys a few times during the call to jump in there. And if you're watching on YouTube, well, I'm sorry, you're probably watching in the future and we've ended, but I appreciate you watching. Anyway, so I'm going to quickly introduce our amazing panelists for today. We have Kimber Lockhart, the Chief Technology Officer at One Medical. Bharat Sutariya, the Chief Medical Officer of Population Health at Cerner, Ryan Smith, the Chief Information Officer at Intermountain Healthcare, and Rennee, the Chief Medical Officer at Heal. I'm going to let each of the panelists explain themselves and their companies a little bit more than I possibly could, but I also want to start things off with a question for each of them. So I'm going to go through, and I want to hear from each of you what you feel has been the biggest challenge for you and your company during this pandemic. Kimber, let's start with you.
Wonderful, thank you. I'm Kimber Lockhart, the Chief Technology Officer with One Medical. For those of you who are not familiar with One Medical, we are a national primary care practice with a membership-based and technology-powered model. I think one of the biggest challenges for One Medical throughout this pandemic has been similar to that of many provider practices. We previously had a robust offering with folks able to take virtual visits, to come in and book an in-office visit. And with the shelter-in-place mandates and the lockdowns, we had to rapidly adjust the balance of our business from being both in person and virtual to having a much stronger virtual component.
Great, Bharat, let's jump to you.
Good afternoon. So Bharat Sutariya, I'm a Vice President and Chief Medical Officer at Cerner. And as you guys know, Cerner is the healthcare information technology company. So our challenge is probably three-part. One, we had to move large workforce of 27,000 plus across the globe from a physical, working environment to virtual, which was accomplished, over about 3 days successfully. So that's one big challenge. Second is we support a very large swath of healthcare delivery in the United States and globally. And we had to, while we're doing internal change of working virtually, we had to make sure that we can support our clients and enable them in the toughest journey they've had in a long, long time, right? And then third, do that in a manner while keeping our associates safe so that we are here to work and continue to serve, our clients.
That makes sense. Ryan, let's jump to you.
Hi, good afternoon, everyone. My name's Ryan Smith. Newly Chief Information Officer at Intermountain Healthcare. In fact, just starting my third week on the job. As luck would have it, I actually spent about 19 years at Intermountain Healthcare. It left about 7 years ago. But as I talk with my colleagues across the organization and with my employees, some of the big challenges that we've experienced during the pandemic is really scaling, both for remote workers that historically had all been in office or in facility, and just a massive remote type of an effort. Likewise, also scaling our services further for virtual visit capabilities. I think like many other healthcare organizations, we saw many digit increases in those virtual visits, and that continue, and continue to grow. And also, just one other one I'd mention is just the rapid development and deployment of COVID-19 related analytic development efforts have just been really key, for tracking all kinds of things, for predicting, resurgences, for, following supply type needs and things like that. So it's just been an all hands on deck type of an effort.
I see. Last but not least, Rennee.
Thanks for having me, protocol team. My name is Rennee Dua, and I'm one of the founders, and I'm the Chief Medical Officer at HEAL. At HEAL, we specifically deliver house calls to patients, but we use a software-enabled platform to deliver telemedicine calls in addition to remote monitoring devices. And ironically, without foreseeing a pandemic, we were well prepared because we use so much software to deliver access to our patients. That being said, as all of us who are a part of primary care know, patients still have to leave the home at time to get preventive screenings, for example, mammograms or colorectal screens, and they're scared. And so this element of their lives is not being managed well at the moment. We've seen lots of literature that children are not being vaccinated on time, or that patients are not getting their annual physical when it's due. And so again, with HEAL, we're working very diligently to deliver that access, but for some components of the physical exam, they must leave the home.
I see. I think that was great. Thank you, everyone. I think that a lot of what you spoke about kind of hits the things that we tried to get into in the manual. And I think one of the most visible parts of the kind of revolution that has been forced upon a lot of people just because of what's happened in the last few months has been telemedicine. There have obviously been proponents of it for years, but it's for many people, it's been the only way they can see their doctors. So the first question I have, and I'd love to hear all of your opinions. I'll start with you, Ryan, at a large healthcare system. Where do we think, or how much do we think that telemedicine will be here to stay? Obviously, it's a necessity right now, but will the amount of time doctors spend with their patients virtually rise as a result of what comes after the pandemic?
Yeah, sure, Mike. So yeah, I think we absolutely see it staying. Will it continue at the current rate that it is? Well, we'll see. A lot of that kind of depends on if there's some continued relaxing of reimbursements and things like that we've seen. Assuming that there will be, I think the percent's going to be highly dependent on the stage of the individual health system's maturity, especially as it relates to value-based care. A lot of people have suggested, it'll be somewhere in the neighborhood of around 20%. My guess is we're going to see an increase in telehealth beyond replacement of some clinic visits, but again, time will tell. And maybe 20% replacement and an additional expansion as the barriers to visit are lowered in healthcare, like we've talked about. And these could be around care coordination, et cetera, which in the past, would lead to a visit that may an in-person visit that maybe now, can be done online.
Mm. And Rennee, I feel like that's something that HEAL does already, is that kind of the virtual aspect before the physical is needed. Do you see this being more of a trend moving forward?
Yeah, I absolutely think telemedicine is here to stay. And I think it's great that people don't use the emergency room or urgent care for unnecessary reasons. And so I do agree that the payers will come around to relax a lot of the reimbursements they were previously not doing. In other words, many times when a doctor makes a phone call to her patients, she might not be paid for that time, but she is offering a wellness plan, or she is offering care coordination. And in doing that, she's encouraging her patients' compliance. So I certainly think it should have been reimbursed the way it is now. I think it will be here to stay. And then I think the third part of it is the remote monitoring piece, because I can tell you right now, we use a device that we patented called the HEAL Hub. And that device not only lets us know how our patients' values are going in the way of their blood sugars or their blood pressures, but frankly, we know they're alive. We know they're well, because if we can't be in the living room and they're not connecting with us by video chat, we see their data coming. And that gives us enormous peace of mind. The idea that we can then have a video chat and discuss their data, it's worth it, right? We can manage insulin or weight, management for a congestive heart failure patient by video chat, and we've done what we need to help them without having them leave the home.
Yeah, I've definitely noticed that in my research for the manual. I personally have a heart condition that I go to the doctor once a year for an EKG, and assuming nothing gets worse, that's all I do. But that's not necessarily the best way to look at. You're making a decision based off of one piece of information every year.
That's right. You want to have coordinated care.
Kimber, I'm wondering how that works for One Medical moving forward.
Yes, One Medical has had a telemedicine or virtual care component since very early on. And we've learned a couple of things over the last several years of delivering both virtual care and in-person care. One is that it's really important that providers get familiar and comfortable with the art of providing care virtually. It's different than providing in-office care, and the tooling those providers need, the training and support that they need shouldn't be underestimated. The second thing that we're seeing is that there is a comfort curve with patients and their familiarity with using virtual care. One thing that has happened out of this pandemic is that patients were forced, if you will, along that comfort curve, and many had a chance to try virtual care for the first time. So we're seeing this evolution in the comfort level with providers providing great virtual care and with patients in getting care virtually. And so ultimately, I think that both of those things set us up for a future with much more virtual care. We've also learned that it's really important, and patients are increasingly recognizing that having integration between their virtual care and their in-office care makes each much more effective. So I think we'll start seeing the connection between what was largely disparate provider groups providing either virtual care or in-office care, and we'll start to see more blended models where, depending on the need of the patient, care can move between virtual and in-person channels seamlessly.
I feel like that's a really good segue into Bharat, because the data that underlies all this and the patient doesn't exist in a vacuum. They do go to all these different specialists or use different tools. So I'm really interested in the EHR perspective on this and how you think things will change, Bharat.
Yeah, first, as a practicing emergency physician, I fully endorse what Rennee, stated, which is if we can use virtual care capability and allow patients and consumer to do triaging and get care in a safer environment, in a comfortable environment that don't need the resources of emergency department, absolutely we should enable that, right? So I see the practical benefit of it. But beyond, we all have seen the stories about how well telemedicine has been adapted in this COVID situation, and in fact has been vital in maintenance of a care for chronically ill individuals, right? So we see that, but I do see it continuing, as Ryan stated, much beyond, because telemedicine helps us solve access issue, because right now you try to call between 9 and 5 and try to squeeze into a primary care office is not always practical, right? So telemedicine helps you with access, with experience, and then third, I'm going to say more with that continuous engagement model, right? You don't have to worry about it's weekend or night. There's always a clinician that can be available by virtual type of environment. So I do see this movement, as sustaining and actually building upon, right? And as that happens, I do think there are some enablers that have already been there from a policy perspective and technology perspective. And I think you're going to see much more enhancement to those, right? So from a policy perspective, a lot related to in the 21st Century Act and previously meaningful use that liberated that data from an interoperability because that data is vital to enable the entire ecosystem that bolts on to the EMR and EHR platforms, right? That allows these special applications to function, by various different, specialty providers, right? So that data from a policy perspective is important, but then also from a practical technology perspective, I think with the advent of the cloud, the big data, and the interoperability that's advancing, I think these are all enabler for new forms of healthcare delivery, with telemedicine being one of it, but there'll be multiple forms of that actually enable care at distance in a much more robust fashion than we've seen to date.
I see. Well, that kind of hints at something Rennee said, and it was also going to be my next question, which is I feel like there are two kind of data issues here, where there's the interoperability of existing health data, but then also data from new sources like wearables and IoT devices and other devices that are being used to monitor the health of patients at home. And I'm really interested in hearing more from each of you, how you feel that data should be integrated into the healthcare process, but also how regulations need to change. Rennee, I'll start with you.
So from my purview, that data is, again, a part of care coordination. And if you take, for example, the medication and pharmacy industry, right? Every month, patients are receiving medications on auto refill. They have no idea if they need them, why they're taking them, if they're serving a purpose. And if you start looking at their data, for example, again, if they're a person with congestive heart failure or high blood pressure, it's often that they're not even using them correctly, right? So the incorporation of data with a blood pressure cuff or a patient's scale and checking their weight will allow you to measure whether or not that patient's management is optimized. Once their management is optimized, of course, they're not using the hospital, they're not using the emergency room, and frankly, they're staying at home, where right now they're certainly safest. But let's face it, the ER and the hospital aren't the safest place to be anyway. You're exposed to other ongoing issues. Separate to that, though, is of course the issue of privacy. And when we are sharing all this data, and I know that everyone is aware of the Fitbit situation right now, it is very concerning about how this data is being used, with whom it's being shared, with whom it's being quote unquote televised. And I think there's something to be said for that as well, right? When we think about patient privacy, which of course for everybody on this panel is paramount, we want to make sure our patients' health data is protected and that they are in control of where it's going and with whom it's being shared. So I think that's something we're going to learn more about as time passes.
That's really interesting. And Bharat, from a records provider's standpoint, how does that data, how do those new forms of data that maybe there isn't the kind of HIPAA compliance structure already in place, how does that work moving forward? What needs to change to allow that sort of data to be viewed in the same way as data collected by a doctor?
Yeah, I think you're going to see a parallel evolution on multiple fronts, certainly on the policy side, but also on the leveraging the new tech, and creating a layer above the traditional EMR. So traditional EMRs were largely designed to capture that transaction that occurs between the provider and the patient, right? And I think you already see the movement. So, for example, the Healthy Intent platform that Cerner has, it's about the person and the longitudinal record as well as the longitudinal plan. So what the next 4 or 5 year holds, I think, in the healthcare technology is really to enable a 360 view of that person or the consumer or the patient, whatever the persona you want to apply, and from every aspect, not just from clinically generated data, but person entered data, device data, as well as myriads of data that are out in the open source community, ranging from socioeconomic to environmental data, all coming together to paint that true 360 view of an individual, and then running intelligence on top of that data in a continuous manner, so almost becoming a surveillance function to then generate and update a evolving longitudinal plan, so that no matter where you go get your care, through the advanced interoperability, you have access to the latest longitudinal record, as well as the latest longitudinal plan across the entire lifespan, all the way from the time when you're healthy till the time, should you have a chronic disease. And that way, the entire healthcare network or the ecosystem is operating on a strong foundation of that 360 view with that longitudinal plan.
I see.
And that's what we're trying to enable right now.
I see. I feel like for a lot of the devices that are out there right now, I wear an Apple Watch. They're not cheap. It can do a ton. I'm amazed at what it can do and what's been approved even by the FDA or cleared. But they start at $300 and they go up from there. And Ryan, I wonder from a healthcare provider standpoint, for a system that's across a large area and probably a large socioeconomic variance, how do IoT devices like this? Yeah, the prices will come down. We know Moore's law and things like that. But how do you create a system where this kind of stuff can be offered by a healthcare system when there is such a gap in the socioeconomic factors of people coming into any hospital?
Yeah, it's a great question, Mike. And we, like so many other communities of care, see a lot of disparity and a lot of, community health needs and a lot of those that aren't always well addressed. And so, our company invests and donates a lot in terms of resources, technology dollars, et cetera, to help helping to address a lot of those community health kinds of needs and being able to connect with other resources in the community. It could be the prison or the jail system, and it could be education. It could be, we still have a lot of opportunity across the nation, to figure out how we can better connect data, how we can better manage those transitions of care, how we can get those, case and care managers from these different entities, not all directly healthcare providers, obviously, to rally around and to help with this. But so there's still a lot of need there, Mike. No doubt about it.
I see. And Kimber, I want to hear your opinion on this, but I also want to give you the next question because I feel like it's I really want to hear your thoughts on it. I've got to believe that the pandemic is changing the way that healthcare providers think about their physical spaces. Obviously things are tougher now, but even after this, has the pandemic changed the way that One Medical thinks about its clinics?
Thank you for asking. It's an excellent question. And I think that with the shift towards virtual care and with the increasing comfort of patients and providers with virtual care, if we didn't pause to think about the role of physical space in our strategy, that would be a mistake. And so as we are evaluating how we expand, we do believe that in-person care is incredibly important and isn't going away. There are many things for which in-person care is the only way to provide the examination or the care that a patient needs. On the other hand, we've started to discover that there are some things for which virtual care may in fact be better. There's some conversations that are best had with a patient in a setting they're comfortable in. There's certainly some behavioral health conversations that need to happen that are that may be better virtually than in person. And as we learn more and more about which types of care make sense where, we can start to balance how care happens across our system. One of the things we've put a lot of work into from a technology perspective is how do we help patients find the right way to get care for whatever might be affecting them. So we know today, just go to the ER because it's the only thing open is not a good way to make a decision on care channel. But what if we were able to get much more granular in understanding what a patient needs, what their health history entails, and then helping them to determine, is this something where you need a one-time virtual visit? Should you just come into the office and save a step? Or is this something for which going to urgent care in the emergency room is the appropriate next step? So we've been working on using machine learning and other strategies to understand what a patient's needs are and route them to the right place to get care.
I see. That's really interesting. And Ryan, I've got to believe there must be a similar thought at Intermountain in terms of, kind of being conscious of space as a result of the pandemic. Are there any changes that have happened already, or things that you're thinking about where technology can perhaps, save people from unnecessary trips?
Yeah, absolutely. And not only just unnecessary trips, but when they do need to make a trip, a lot of rethinking, during the pandemic around how do we minimize the number of people that are in the lobbies and waiting rooms at a time. That's, taking a lot of new processes, new technologies, things like that, so that, for urgent care visits, for whatever the case, being able to fill forms out virtually before coming in, or perhaps even while sitting out in your vehicle, waiting, to be notified to come in. A lot of curbside triage kinds of procedures have had to come into place, which is, forced kind of mobile extensions of our EHR technology out into the parking lots. And I mean, the list just goes on and on and on, with the kind of considerations. It's been particularly in regards to our ambulatory space. I think, the way that we're thinking about physical space. And so, not to mention, or not to say that doesn't impact our hospitals and everything else as well, but it seems like in that ambulatory space, it's been really prevalent, the type of changes that have had to be thought through, ironed out, evolved as time's going on, and technology and data are playing a big role in that.
I see. And Rennee, for HEAL, it seems like, it's kind of always been the opposite. The doctors come to you, as it were. Are you seeing an uptick in people wanting that type of care, in healthcare providers wanting to give that type of care now?
Yeah, absolutely. We haven't had to rely on office space, and as such, we've been very busy. And as I had mentioned, we also were prepared, unbeknownst to us, for a pandemic. So it's been really nice to see, as Kimber said, patients evolve into becoming more tech savvy. It's been awesome to see our physicians and providers want to be a part of it. But I will say, we also keep things simple. We at HEAL, we have always had a toll-free number, right? So if a patient wants to call us to have a conversation, they don't need any software to do that. And we try to make sure that with all of this technology, we're still delivering access.
I see. And it seems like it's also, there's a lot of the conversation, at least on the consumer side, is around having people access Zoom for the first time, or have a real uptick in e-commerce and things like that. Those are the big storylines. But I've got to believe that the learning curve is there, if not more, for a lot of doctors. And Bharat, I'm wondering if there's been any kind of work that Cerner's done to make this process, especially on telemedicine, but just like, I can imagine a doctor who has only ever worked in his clinic for 40 years, is now stuck at home, still wants to see his patients, is having to log on to a cloud system to get that information, has no idea how to do that. So how is that process happening right now?
Yeah, so I think there's three different components to it. So there's the initial access, which system do I use and how do I access it, right? And then the second is about the learning curve, about just training so that I can conduct my visit. But I think third, which is important for us to understand, which is the efficiency. We talk about clinician burnout in our normal operation, and we got to be mindful of not creating a different kind of burnout now that people are working virtually and doing telemedicine, right? So efficiency is important. So the work that we're doing is to do an integrated experience. So the clinician would still log on to their EMR just the same way they would log on if they're physically inside their clinic, and then integrating the virtual experience within that EMR. So their schedule book looks like their normal schedule. And instead of a patient showing it physically, they have the concept of patients waiting in a virtual waiting room or making that connection as they get on and literally be able to click on the schedule slot and launch their video experience. And then as they're conducting their visit, to be able to do documentation side by side right inside the EMR, right? So we're trying to minimize the disruption of that workflow from a clinical end as much as possible. Then on the consumer end, consumers access various different digital front door, some call it portal, some call it, various branded experience. And then how do you enable consumer to go to their normal, health system trusted and branded experience and be able to launch a visit right from there. So there's both ends of it that we're trying to connect right now.
I see. And as a journalist, I know that experience of trying to pay attention while also writing notes and doing it all on screen. It's not easy. I want to shift gears slightly. I want to pause first and say, for everyone listening, just a reminder, if you have questions, please put them in the Q&A section, and we'll check them out. And I wanted to shift gears slightly because I was reminded, actually today, before we had this conversation, I got a bill from my doctor for a whopping $14 that I paid 2 months ago. And I've gotten 3 bills since then. And I called them to explain, and they asked me to send a screenshot of my credit card to show that I had paid this. And that doesn't seem like a very 2020 solution to paying for healthcare. And a lot of the stuff I heard while I was working on the manual is that the way that we pay for healthcare and the way that healthcare is built needs to change. I've heard from there's a lot of companies, some on this line that see the value in a subscription model, and some see it in a more kind of atomic billing structure. So I'm really interested to know, as the way that we get healthcare changes, the way that we have wearables that's feeding information to doctors all the time, maybe texting with doctors or emailing, how that billing process is going to change, both for the healthcare systems and for the end consumer. Ryan, I think I'll start with you and your thoughts on that.
Yeah, great question. Well, obviously there's a lot of different, reimbursement / financing models in healthcare. The range. I mean, right here on this call today, I think we represent multiple ways that this can happen. Talking across the country about kind of the traditional fee for service proposition, where individuals are either typically commercially insured or government insured, whatever the case may be. It's really problematic. There's a big disconnect. Consumers of those healthcare services, increasingly are in charge of that first dollar of spend, through high deductible health plans and things like that, using their HSAs. However, we're all very accustomed to receiving this is not a bill multiple times. Like it sounds like you're probably articulating, Mike, and that's been an experience, I think, we in this country have all kind of grown accustomed to. But the reality is, as the country is working to pivot and work more into a fee for value kind of a model where we recognize the, value-based care kinds of models where healthcare systems and payers are incented, to keep people healthy at the end of the day, where, there's basically a monthly premium charge for that. And then, when we can start to flip the equation more to that type of a model, then that really starts helping a lot with the way that consumers experience that financial part of it, because today you're right, for many Americans, it's a very challenging kind of a process to understand what these bills mean, to know which ones need to be paid, how much of it is their responsibility, how much of it is their insurance company paying for, ... So we absolutely need to continue that momentum towards pivoting to this value-based care type of a model where we're incented and paid for keeping people healthy.
Yeah, I grew up overseas, and when I first came here for my first job and did healthcare, I was inundated with acronyms, and I still, it's been like 15 years, and I still don't really know. But Kimber, I'm really interested in hearing One Medical's perspective on this.
Well, I dream of a day in which access to primary and preventative care is unrestricted by our financial models in healthcare. There have been multiple studies that show the impact of thoughtfully delivered high access primary care on the overall rising cost of care in this country. And so we can discuss at length all of the different flavors of models that don't restrict access to primary care. But my hope is that we can center together on ways to increase access where people need it most.
I see. And Rennee, I'm interested in your opinion as well. Has it changed at all as well because of the pandemic?
No, at Heal, we have proprietary software that allows a patient to know his eligibility up front. So if he is in network and we can accept his insurance, we will see him. If he has a deductible or a co-insurance that's due, we will collect up front. So patients that use our platform do not get bills. And this is a very important concept to us, that you shouldn't have the confusion that you're having, $14 for an EKG, right? And then separate to that, I think, is this notion of moving from a fee-for-service model to a value-based care model. And so as patients become members of the Heal platform, then they will know what's included, right? Will the telemedicine visits be included? Is the Heal Hub a part of their continuity of care? And all of that value will then go into hopefully not taking too much from the patient at all, and frankly, using their insurance to run a business model that works. I think the last thing is we've always had a cash pay price, again, to deliver access, and it's inexpensive in the hopes that a patient uses our platform instead of going to the emergency room or an urgent care, or frankly, ignores the problem altogether.
That's the simplest, but definitely the worst solution. I have a question on the line that I want to get to before we run out of time here. So I have one more question for everyone. But this one I thought was pretty interesting. And this isn't something I had thought about, but presumably is something that is on a lot of the providers' minds as a result of the CARES Act. There are companies and doctors that would have been using telemedicine for the first time as a result of the pandemic. And actually paying for that, the infrastructure that might be needed. I could see it being possible that somebody didn't have a good enough wireless system in their house to be able to provide telemedicine to a patient. How has that been addressed at medical services? Ryan, I'll start with you. How have you gone about making sure that your doctors can provide telemedicine?
Yeah, great question. I've got to admit, I haven't been so close to that side of it yet to know what we have done. If you're referring
kind of a few weeks,
to more of the in-home side of helping our caregivers and providers from a connectivity perspective, I'm not exactly sure.
Makes total sense, I guess. 3 weeks, right? Kimber, I'm interested in how One Medical's been handling it.
One Medical has long had a group of remote providers who help provide thoughtful primary care to our patients. And so we've had a few years head start on this. And there's no magic solution here, but ensuring that folks have access to a set of standards for service and connectivity. Turns out it's that, but it's also things like making sure there's a good space in which to handle those visits. So those are the kinds of things that are part of helping providers onboard to being able to do great virtual care. Further, as the pandemic has gone on, we have discovered that there are times in which it is completely reasonable to run a virtual visit from an office in between other scheduled office visits. So really making it the case that virtual visits can be conducted nearly anywhere can help us provide the kind of flexibility that we need for our team of providers.
I see. Well, we're running close to out of time here, and I really wanted to get everyone's opinion on this last question. And I'm going to do it as a two-parter, just to use up as much time as possible. But so I'm really interested in if any of you have found since the pandemic started there to be some transformation in healthcare, some transformation for your company that wasn't necessarily on your radar. I mean, people have been talking about telemedicine, people have been talking about at-home diagnostics for a while. Was there anything that didn't jump out until the pandemic started? And then the second part of the question is, what is the biggest change you expect to see in the industry in the next 5 years? So, just a light, small question to end on. Bharat, I'll start with you.
Sure. Yeah, so I would say there are a lot of innovation that were in its infancy stage that this pandemic has helped bring it to the mainstream. But one particular concept I described is, I'm going to call it the touchless care experience. So all the way from time you arrive to a facility, to entry into the facility, to conducting your encounter or visit, to being discharged, there's so much physical touch involved everywhere. And almost all of the ownership of coordinating that has been left to the consumer. From the time you park your car to find your clinic to sign into the paper clipboard, unfortunately, it led many places, right, till you wait and so on. And I think that entire touchless experience is a highly valuable asset to work on to enable that consumer experience. From the time you arrive, based on the GPS, knowing that the patient arrived to facility and start pushing advice to say, here's the path to your clinic. And by the way, let's not make you go into the waiting room with 10 other patients. So here's a safe place you can wait. And doing all of that, we have the technology to be able to do that today, and really unlocking that touchless experience, I think is a huge, huge opportunity and something that we are embarking on journey, to enable that. Then your second part questions about what are some of the big transformation in healthcare in the next 5 years. Honestly, there are probably a list that goes hundreds deep, but some quick top of mind is I do think that we're going to move from a transactional experience to more of that continuous experience, so that you can stay connected with your provider or the provider care team at large, through the use of technology. I do think that that is coming. I also think that the use of just the technology around us, the ambient technology, the Internet of Things, IoT, and using that to positively impact lifestyle, creating healthy behavior, but also taking care of chronically ill, I do think will pick up a significant momentum in the next 5+ years as well, because we now have the advantage of a big data, we have advantage of AI and ML, to really help us, with all that and get it right.
I see. That sounds like a lot. Rennee, same questions for you.
I think one of the things that surprised me per se is how much mental health help people have really needed through this pandemic. And so at once we're touchless, but it's that very interaction between maybe doctor and patient that patient needs, right? The idea that sometimes my patients come to see me, or I'm seeing them in their home, and I'm honestly holding their hand and telling them it's going to be okay. The fact that that's sort of gone away, I think, has really affected a lot of patients. It's a very intimate relationship between physician and patient. And so again, the business of being able to use the phone or video chat to do teletherapy, I think has been profoundly helpful for patients.
I see. And Ryan, same questions to you. What's changed, and what do you see as the big changes ahead?
Yeah, so you know what's interesting, rather than just wholesale transformations, I think what we have experienced at Intermountain have been mostly acceleration around transformations that were already underway, if that makes sense. You know, so for example, telehealth expansion, you know, transitioning from more of a disruptive kind of a technology and care delivery model to being almost overnight kind of normal. You know, consumerism and data transparency in the form of things like open notes and real-time shared results and you know, those types of things now just being very commonplace because we have to. And in interoperability, you know, same thing. It's just we are already on a trend, and it's just everything's just kind of an accelerated. In terms of some of the big changes that I see over the next 5 years, kind of like I talked about earlier, those that haven't really evolved their models, I think will be in peril, and I think we will see, you know, certain provider organizations will fail as a result of it. I think we're going to be back to seeing, you know, broader merger and expansion again by virtue of those that aren't able to make that shift from fee for service to fee for value. I see huge advancements in how data and analytics are going to be leveraged, in particular, like Bharat mentioned, around AI, you know, helping with voice type services and really helping to support automation and advancements in predictive models. And, you know, we just have so much opportunity in healthcare. A lot of the data is there. We're just not, you know, fully tapping and leveraging it yet. And a lot of the tools are obviously there as well. And, you know, hopefully, kind of bottom line, that we'll see this acceleration of evolution past, you know, out of our current state of healthcare, where we're the world's most costly healthcare system, you know, to something that, you know, puts us on much more competitive terms from a, you know, GDP perspective, et cetera. And, you know, I think the pandemic is really forcing the country holistically much more rapidly than we otherwise would have, you know, towards that type of a model.
I see. And Kimber, last but not least, for you.
Thank you. The one thing I wouldn't have predicted is the need to help employers determine when it's safe to return their employees to an office setting. So One Medical works with many employer clients across a number of different industries. We provide primary care for their employees. And recently we've been brought on board to help our clients think through the strategy, timing, and approach for when it makes sense to bring employees into an office setting, and how we can help with screening and testing in order to do so. So understandably, that's not a part of our business that we saw a year ago, but it's been a really neat opportunity to partner together with our clients so that we can help folks get access to the testing and screening that they need to take on the roles that need to be in an office setting as safely and thoughtfully as possible.
Nice.
In terms of where I think things are going, I'm going to go right back to the beginning and echo what Bharat said. I think in the next 5 years, we will see a breakdown between an encounter-based view of healthcare to a continuous view of healthcare. It's going to be less about waiting for a patient to come in and then reminding them about the 3 preventative screenings that they forgot to get last year, and much more about establishing communication channels that are bi-directional over the course of a patient's longitudinal health journey.
I have to say, as a result of working on this manual and this conversation today, I'm truly excited for the future of healthcare, even with everything that's going on. This has been a fantastic conversation. I really appreciate everyone's time, and everyone listening on the line. Thank you for making the time to watch. Look forward to seeing you all soon. We're having another one of these in a few weeks, I believe. You may or may not have the same host. But again, thank you everyone for taking part, and have a good one.
Thank you.
Thanks, Mike.
Yeah.